Central apneas, you see basically a flat line all the way down. So nasal pressure flat, airflow flat, thorax belt flat, and abdominal belt flat. And you often see a crescendo, decrescendo airflow pattern here. So they start sort of slowly taking breaths, and then bigger breaths, and bigger breaths, and then slowly down. That's what it's supposed to look like, right? That's what all your studies look like at nighttime. Nice, normal breathing. No, not so much. Okay, so hopefully this will work. This is just a little picture of what happens. Yay, it worked. So here you have normal breathing where your air flow is very nicely getting in, not occlusion of the posterior pharynx here, no narrowing, but over here we see narrowing or occlusion. Okay, so definitions, again, this should all be a review, obviously, to most of you. I don't know how many people are scoring studies or not, but hopefully this is somewhat of a review. So an apnea or hypopnea has to be 10 seconds or longer in length or for it to be scored. Hypopneas in general have been the majority of things that we see when we score the studies. The Sleep Heart Health group has done numerous studies sort of here and there, but they did one in 2008, and they showed that a hypopnea with a 4% or more drop in your DSAT was independently associated with cardiovascular disease. And so this is, it reinforced, Medicare's criteria that you have to have a 4% more drop in your O2 sat. AHI is the number of apneas and hypopneas per hour of sleep. An apnea-hypopnea index greater than 5 with symptoms of excessive daytime sleepiness is the definition of sleep apnea. Just as a note, if you have an apnea-hypopnea index greater than 15 and you don't have daytime sleepiness, but say you have high blood pressure or you've had a stroke or something like that, or an arrhythmia, that automatically rules you in. 1 out of 5 adults have mild OSA, AHI greater than or equal to 5. 1 out of 15 adults have moderate to severe OSA, greater than or equal to 15. These numbers were obtained, I think, from information data that we had, 10, 20 years ago. I think the numbers are higher, and I'm going to talk about a study that was just done recently that may show that they're a little higher now. And then the progression of sleep apnea increases over time. This is a new slide that I put in last night, and these were 2 studies done in 2010 and then actually last month. And one of the studies here showed that they just sort of looked at hospital patients. They didn't do sleep studies on them, but they had them fill out a questionnaire. And they found that 157 out of 185, so 81%, were high probability for OSA. This is an interesting study. This is the one I wanted to talk to you about. So they looked at women. So they looked at 10,000 women, and they had them fill out a questionnaire, and then they did sleep studies on them because they didn't really know the prevalence of sleep apnea in women. We sort of know that it's more prevalent in men, but okay, well, how often do we see it in women? 50% of women between the ages of 50 and 70 had an AHI greater than 5. Which I thought was kind of astounding. And it was related to age, obesity, and hypertension. Women don't report daytime sleepiness. Key. This is a key thing. And I think this is a key thing because years ago, when we were learning more about heart disease, women often don't come in with the classic crushing chest pain, left arm pain, going to the jaw, yada, yada. That's a man thing. I mean, granted, women get it too. But women will say, oh my gosh, I'm short of breath. I just can't catch my breath. And they're having a heart attack. Well, it's not chest pain, it's shortness of breath. Especially in diabetic women. They might just present with shortness of breath, and that is a heart attack for them. Well, when we run all the numbers and look at their EKG and stuff. So I think the key thing here is that women present differently than men. I think that's just sort of the bottom line. Also in that study, they showed that 13% of women between the ages of 50 and 70 had an AHI greater than 15. So I think these numbers are more telling in terms of the prevalence of sleep apnea in community, and it's probably not as low as that other slide that I showed you. Okay, so let's talk about central apneas a little bit here. This was a study done in men, Sleep Heart Health Center, Sleep Heart Health Study did it, and they looked at ages. So men between 20 and 24, really no central apneas, and they defined it at 2.5 per hour or more. And then 45 to 64, there's an increase a little bit here, and then over 65, 12% had centrals. And so it definitely increases with age. Central apnea index overall throughout the whole thing, greater than 1, 9%, ages 40 to 97. Higher incidence of centrals with diabetics, people who have heart failure, LV dysfunction, left ventricular dysfunction, and who have had a stroke. And there are fewer women with heart failure that have central apneas in general. If you have a central apnea index greater than 15, 40% of men had heart failure. Okay, so let's talk about pathophysiology a little bit here. So you have a small airway opening. Two big things sort of happen. Number one, you get airflow resistance. So you can't sort of get the air in and out as well because there's a little bit more resistance there. And it's directly related to the diameter of the tube that it has to go through. Now, before I became a doc, I actually got an engineering degree. So I have a master's in engineering, and I love this course, Flow Dynamic Theory. And basically, it was all about flow through tubes. It was really cool. But anyway, the bottom line here is the more narrow the airway versus a bigger airway, it's going to be higher velocity, potentially more resistance coming through this thing, smaller airway versus a larger airway. So if you're narrowing your airway in the back, you're going to have more resistance. So the other thing that happens is that, and I explain this to my patients all the time, that you have the diaphragm, which is your main respiratory muscle, has to contract down. When it contracts, it moves down. And then when it relaxes, your air goes out. So inspiration is an active process. So when we inspire, we take a breath in, our diaphragm contracts down, and it pulls that air in. It creates a negative pressure. When we expire, that's a very passive process. Our diaphragm just relaxes, and our air goes right back out. So what happens is when you're narrowed, the diaphragm actually has to create a larger negative pressure to bring that breath in. So because of these two things of increased resistance and increasing negative pressure, you increase your pharyngeal dilator muscle activity to maintain your airway, and this is during wakefulness. And then what happens? During sleep, you sort of you lose the mechanoreceptors' ability to sense that they need to do that. You lose the ability of your muscles to be able to keep you open, and then your airway flops closed. So now you get narrowing or complete collapse, intermittent collapse. Your oxygen levels intermittently go down, and your carbon dioxide levels intermittently go up. And this stimulates your chemoreceptors in your brain to say, okay, start breathing, and then stop breathing, and then start breathing, and stop breathing, and then you arouse, and you get acute and chronic sleep deprivation. So a couple of these next slides are just sort of harder core pathophysiology of sleep apnea. Deficient pharyngeal anatomy we already talked about. There's an instability of your control, your ventilatory control center, which is in your medulla oblongata in your brainstem, and I'm not going to necessarily go into all of that, but there's an instability there. There's variable surface tension of the airway, which relates to the resistance of the air going in and out. There's asynchrony, or the timing of your breathing gets disrupted. Increased arousals, variable upper airway muscle control, and then there's also loss of lung volume, longitudinal contraction, and then your airway becomes more collapsible.